Now, who is served by this system? So if we're just thinking of the Maryland public mental health system, which is primarily Medicaid funded, it's about 50-50 male-female. It's actually 52% female, 48% male. It's a majority African American, so about 48% African American, 44% Caucasian, about 8% others. So it's skewed more toward African Americans, which is pretty consistent with income distributions. Age-wise, it's about 46% 0 to 21 and about 54% 22 and over. If you look at the age breakdown in 2015, about 70,000 adults were served by the public mental health systems. That's individuals that are 22 to 65. So there's a small geriatric section that's funded by Medicaid, but the majority of individuals over 65 are funded in the Medicare system, which is not the Maryland public mental health system. Medicare dollars, as we've discussed in class, are all federal dollars, whereas the Medicaid system is a joint state-federal funding effort, but state administered. So there's primarily an adult system. There's about last year there were about 30,000 individuals, children that were served by the system, and another 20,000 adolescents, and then a smaller number, about 8,000 transition-aged youth, so those folks in the 18 to 22 range. So basically, it's a 50-50 split between younger folks and adults. So how much do we spend on the public mental health system? Now remember, a lot of the money comes from the feds. So state, but just looking at claims expenditures for the public Maryland mental health system, as this graph is showing, there's about $750 million that is spent in the Maryland mental health system. So about $750 million spent in the Maryland public mental health system based on claims. So that includes both the federal match and the state of Maryland match, as well as the other state of Maryland money. That breaks down to about $4,500 per person. So $750 million total per person. That breaks down to about $4,500. That's in 2014. The numbers for 2015 aren't quite ready yet. And you can see here where the money goes. So the vast bulk of the money goes to pay for Maryland's fee-for-service system, with a smaller chunk of money going to pay for grants and contracts, state institutions, and an even smaller amount of money going to pay for program administration. So the bulk of the money is paid through the Maryland mental health through the Maryland Medicaid system, and then another chunk of money goes through that contracts and grants for special programs like crisis care or some specialty programs. If you look at where those services are purchased in terms of inpatient, outpatient, et cetera, the vast majority of money goes to pay for outpatient services, and you can see that in this chart. This is the number of consumers served by each service. So the vast majority of services are purchased for outpatient services. Obviously smaller numbers of inpatient and rehabilitation services. That being said, the money being spent on these services is a little different than this graph shows, because inpatient services are much more expensive than outpatient services. And as we've talked about many times in this class, there are fewer and fewer people being housed in state hospitals. So this is not the general hospitals like the University of Maryland Hospital over here. I'm talking about state hospitals like Springfield. As this graph shows, admissions to the state facility have really fallen for non-forensic cases. In 2007, there were about 1,200 admissions. 2010, there were 400 admissions. I believe that number has continued to go down over the last couple of years, but forensic cases have remained relatively flat. And so over time, these facilities are becoming more and more forensic oriented. In 2013-2014, in that fiscal year, the state of Maryland received around $58 million from the Substance Abuse and Mental Health Services Administration. Try saying that fast 10 times. So the money is broken out into, the largest block is for substance abuse prevention and treatment. a smaller amount of money for community mental health services, block grants. There's some money for homelessness and a few other smaller grants, as you can see from those top four groupings. And then there's some discretionary funding. But you'll notice that these dollars are primarily spent on substance abuse. And what you see here is a historic path-dependent kind of situation where most mental health coverage was funded through Medicaid dollars, and so we could keep cutting these block grant numbers down and still fund the public mental health system, where substance abuse was basically kept out in a much more exclusionary way than even mental health. And so in order to fund substance abuse services, it was primarily through the form of block grants. The Affordable Care Act and Medicaid expansion have really changed the game, though, and we're now beginning to move to a system where Value Options is going to start authorizing and pre-authorizing substance abuse services in addition to mental health services. So the renewal of their contract is going to fold in substance abuse services, which will now be provided through the carve-out. And so what we're going to see in the coming years is a real shift in substance abuse services to more of a mental health model from the old block grant model. So what used to happen is this $30,000 of block grant money would be distributed to the local CSAs. They all had their component, and back in the day, they had their component substance abuse and in addition to the mental health core service agency. Those have now been integrated in each county. But back in the day, they had their own standalone substance abuse core service agency. And then that core service agency would distribute block grant money to local nonprofit providers that would provide substance abuse treatment. That system is being totally reworked. And what we're going to get is much more of the mental health model, where service providers provide fee-for-service services, and it's mostly run through Value Options and the state mental health carve-out. So we're going to see more of a mental health model than we have historically seen. Now, how this is going to shake out in terms of agencies, it's a little unclear. I would love to talk about this in class with you guys because I'd like to hear feedback on what's happening in your agencies. My initial talks with providers are that they're not super excited about moving. The mental health providers, which I primarily work with, aren't super excited about moving into the substance abuse domain, in part because the reimbursement rates are low and the population can be difficult to work with, even compared to mental health. This is not to say that there isn't a lot of substance abuse services delivered in mental health agencies. Comorbidity is a relatively large problem for the mental health agency, which is why these services were integrated to begin with. But we're still really struggling with these two different cultures, where mental health had a real focus on the delivery of evidence-based services by professionally trained providers that were funded through this Medicaid system that was relatively analogous to the traditional health system, where substance abuse was off in its own world, working through a grant-funded system where the local core service agency would give an agency a certain amount of dollars, and they weren't subject to the same regulatory oversight in terms of professional providers providing the services. A lot of folks in substance abuse tend to be peer support rather than professionally trained folks with licenses. That's changing. Historically, there hadn't been the focus on the delivery of evidence-based practice. That's changing. And now the funding system has changed. And how all of this shakes out is one of the really big questions for the next several years in the state of Maryland in terms of this public behavioral health services system. Another unique aspect of the state of Maryland, and this is a really important healthcare experiment. As we talked before, the Affordable Care Act was really primarily about increasing access, not about controlling costs. The state of Maryland has one of the biggest and probably the most important attempt to control costs at the hospital level through its Medicare, Medicaid state waiver for how it funds hospital services. So what the state did is, Prior to this, the old waiver, because the state had a prior waiver, the prior waiver is that the state would do an all ratepayer setting mechanism. So the state would get together with all the hospitals, they would get together with Medicaid and Medicare, and they would set a rate that included all the private insurers, all the public insurer sources. So anybody going to a hospital in the state of Maryland is going to pay the same amount of money for each service. Now that worked okay. There's some evidence that it worked, that it saved costs, although that evidence is a little shaky. But it was pushing the boundaries of what could work. It was fraying at the edges, in large part because hospitals were able to effectively negotiate for higher rates, and so it was really presenting a problem in terms of the cost savings of it. And Medicaid and Medicare were getting concerned that it wasn't working as advertised. So the state approached the federal government with a new waiver request. This new waiver is what's called a global budget. So what happens is the state of Maryland figures out how much money Medicare and Medicaid, and then there's some other programs like CHIP, contribute to each of those hospitals in prior years. And it says to the hospital, okay, University of Maryland Medical Center, we're going to cut you a check to provide services to all Medicaid, Medicare, and CHIP folks served in your hospital. And we're going to control the growth of that amount of money over time, so that you can't just increase costs by doing more fee-for-service. If you think of the hospital as an expensive hotel, they want more people to come in, which presents a real problem for healthcare because they don't have any incentive to discharge people appropriately. If they discharge people poorly, if they don't give people medications when they're discharged, if they don't do these extended services to bridge people back into the community, people will come back quicker. Well, if coming back means more money for the hospital's incentive is not to do those good discharge procedures and other things like that. So the idea behind global budgeting is that the hospitals get all this money, and then they have to provide the best care for individuals within that pool of money. And so the idea is to incentivize services to extend with individuals upon discharge back into the community, to make sure people are taking their medications, to follow up with people a couple of days after the discharge to make sure they're doing well, to do home visits with nurses or social workers, to address substance abuse or other behavioral health problems that might lead to poor adherence to treatment or might lead to more rapid readmission. So the idea is by providing a global budget, the state can control the increase in cost, provide incentives for more preventative measure, better discharge procedures, and incentivize some of these other pro-quality elements. The idea is that the state of Maryland will save over $330 million in Medicare savings alone over a 5-year period compared to the national average. So the idea is to actually save money. The state will limit the annual all-payer per capita total hospital cost growth. That means all the money that, how much money increases over time that goes to hospitals, to 3.58%. So all-payer means whether it's private or public or whatever, they're going to limit the growth in hospital expenditures to 3.58%. And there's a couple of interesting things in here. A lot of what they can control are the public dollars, but what they don't want to have happen is that the hospitals then press up prices on the private insurers. And so the idea is to constrain overall growth, all-payer growth, not just the public side. And then over this period of time, which is a 5-year shift, all the partners will work together on building this system that is built on this global payment system, but that is designed to prevent readmissions. So the idea is that we will reduce the aggregate 30-day unadjusted all-cause, all-site hospital readmission compared to the national average, meaning you come into the hospital, no matter what your condition is, we're going to try and work hard as a state, with hospitals leading the effort because it's now incentivized by this global budget system, to prevent rehospitalization over a 30-day period. 30-day readmissions are a easy-to-measure metric for quality of discharge and hospital services. There's a lot of problems with it, which we can talk about in class. But the idea is that if people are coming back before the 30-day period, that rapid readmission, that says that something didn't go right with the hospital stay and the discharge. That Hospital-acquired conditions will go down by approximately 6.89%. They're very specific with these numbers. 6.89% over 5 years for a cumulative 30% reduction in hospital-acquired conditions. That's that iatrogenic disease issue that we've talked about in class. So that's hospital-acquired infections or other bad things that happen in the hospital. The idea is that the global budget system will present hospitals with an incentive to get doctors to wash their hands before they touch you, or a variety of other mechanisms for reducing infections. Ties are a terrible thing on a physician. Physicians should not wear ties. And the other element is that hospitals now have more of an incentive to invest in population health in their catchment areas. Because, again, if hospitals are incentivized to reduce the number of people coming into the hospital by extending programs out into the community to do preventative care, to do a variety of different services, to engage in mental health care in the community, to improve outpatient services, those kinds of things, fewer people will come into the hospital, which is expensive. It's cheaper to provide services in the community than it is in the hospital. So if we can develop a more robust hospital-based preventative service system, we can dramatically reduce, theoretically, the number of people coming into the hospital. And by doing so, the hospitals will save not only themselves money, but the system money as well. So that's the pie in the sky idea. And there's some reason to believe that these are reasonable solutions. I was just reading an article the other day about how England and their socialized medicine system had split it between the Scottish in the north and the English in the south, and the health system tried different approaches. The Scottish system used this global budgeting approach. The English system used a more competitive market-based approach, and it ended up the global budget in Scotland worked a little better at constraining healthcare costs. So there's some reason to believe that this global budget system will be effective, and the state has really gambled a tremendous amount of resources on deploying this. So it's a really important innovation that's happening right here in Maryland that if it works, this could be a national model. Incidentally, this is also a real opportunity for social workers to engage with hospitals to build a robust behavioral and preventative healthcare system, because we actually know how to work with community members to deliver preventative care. We know how to provide treatment for substance abuse and mental health problems. And so a lot of what this global budgeting does is enable us to be much more proactive in delivering services in community-based settings. And if you're looking to start your nonprofit, I would begin by thinking about something where you work with hospitals to deliver and improve care in these community-based settings. I want to end with a brief report card on the state of Maryland's mental health system. As you probably get by my general cynicism, I think there's a lot of problems with the mental health system. I think there's also a lot of strengths, and we don't focus on that enough. As somebody that's worked in a variety of states, I think I have a reasonably good idea of what can be expected out of a public mental health system. It's always an uphill slog to get people to pay for individuals that we find uncomforting, whether it's substance abuse or mental health services. And people don't like to pay taxes, and these dollars are primarily tax dollars that we're talking about for the public mental health system. And so all states struggle to deliver quality care. The National Alliance for the Mentally Ill, NAMI, is an organization primarily composed of parents or siblings of individuals with mental illness that do advocacy to improve the quality of the mental health system. And one of the things this organization, NAMI, does is deliver a report card. And you can see the map up here on your screen right now. You will notice that there are 0 A's. NAMI is not going to give the easy A. There's no grade inflation here. There are 6 states that get a B for their mental health system, including New York, Massachusetts, Connecticut, Maine, and Maryland, Oklahoma too. But Maryland is a premier quality mental health system. Overall, Maryland does a really good job, according to NAMI, on health promotion and measurement. We have the OMS and other attempts like that to measure quality across the state are very innovative. And while many clinicians really don't like delivering the OMS, it gives state-level administrators an opportunity to look at quality across the system, to be able to evaluate it, identify places where improvements need to be made, and to be more informed about the quality of services delivered by the public mental health system. Financing and core treatment services and recovery services, the state gets a B on. Involving family and consumers, the state gets a B on. Community integration, social inclusion, the state, according to NAMI, could improve their services. And I think a lot of states struggle with this. It's hard to do community engagement and to do it well. It's not something that the traditional mental health system, that integrative approach that we've moved to with Medicaid, is set up to fund. As you know, I'm a big believer in the Dogs for All People with Mental Illness That Want Dogs program. That's exactly the kind of social inclusion element that addresses quality of life issues that's hard to fund through traditional medical and based insurance dollars. There's not really a system set up for delivering those kinds of quality of life improvements. But what I want to focus on in this last little bit is the idea that Maryland, for all its weaknesses and all of the problems that we'll talk about, is a real source of strength nationally in terms of how we organize, finance, and deliver mental health care. We have some really good people doing important work. And my work with the state agencies has, I've personally found people to be very competent, very invested in improving quality. The state has a real focus on delivering evidence-based care. Folks over at the SEC at the University of Maryland, which is run by a guy named Howard Goldman and Di Siebold, they do a lot of work evaluating the quality of the mental health system, making sure that people meet fidelity criteria for assertive community treatment or employment practices. So to evaluate the quality of the services delivered by the agencies and make sure that agencies are delivering evidence-based practices as designed. The OMS system, which is also run by that same group, is a relatively comprehensive attempt to understand quality across different providers. These are not perfect solutions to the problem of paying for quality services, but they're much better than what other states are doing across the board nationally. And I think that it's good to work in a state that has a fundamental baseline that exudes competence. And what we can hope to do is identify and target areas where we're not doing a particularly good job, and to use our existing competent services with reasonably good funding levels to build and extend services such that we can actually one day maybe get an A for delivering the best quality mental health care in the nation.